So good afternoon, everyone. It's a pleasure and a privilege to welcome our guest, Dr. Elena Bitrian. She is a world-known ophthalmology consultant, specialist, and a passionate leader in medical education and research. Dr. Bitrian is a board-certified specialist in both adult and pediatric glaucoma, serving as an associate professor of clinical ophthalmology at the Bascom Palmer Eye Institute at the University of Miami, Miller School of Medicine. Beyond her clinical excellence, she's a dynamic leader as the Associate Residency Program Director for Surgical Competence and the Director of the Glaucoma Fellowship, shaping the next generation of glaucoma specialists. Her journey is nothing short of remarkable. With a medical degree and a dual master's degree in hospital administration and management, and research and statistics from the University of Barcelona, Dr. Bitrian has refined her skills through residencies and fellowships at the UCLA and the University of Minnesota. Today, she's a cornerstone of the Samuel and Ethel Balkan International Pediatric Glaucoma Center, where she serves as the Associate Director of Research and Director of Education. She also plays a key role as the research coordinator for the Childhood Glaucoma Research Network, driving groundbreaking advancements in this field. And now to share her insights, stories, and passion for leadership and innovation, please join me in welcoming Dr. Elena.
Thank you so much for such a warm welcome. I want to express again that I'm thrilled to be here today. And everything I've been seeing is so far super exciting. I was very enthusiastic when I was asked to give a talk on something on a leadership topic, because usually when we are asked to give talks in other institutions, there's always a scientific, educational, but there's nothing, we don't talk about leadership, and I think that's super important. That is something to share our life experiences, where we get there. It can inspire future generations and all of us, because we always continue developing our path. So I want to talk about having it all in academia, balance in academia. And I want to start explaining how has been my own path. Usually, some people have the ideal thing, we plan our life, this is where I want to go, that's where I want to be. But not all the time this happens the same way. In my case, I am from Barcelona. Beautiful city by the ocean, great food as well. It's a land where people usually are very family oriented. They grow up in the same place, they stay there forever. And I was lucky enough to be born in a town very close to the city. And I did go to the university, to medical school in the University of Barcelona. And then I matched on my top program, also in ophthalmology there at the University of Barcelona. So everything was going well as planned, except that I made a mistake. I wanted to see other places. So that was embedded in my brain. I had a visiting professor, a neuro-ophthalmology professor that came, and I just met him. I was I would love to spend 6 weeks. I have an elective. I can go to Wills Eye. So that's what I did. I just went. It was a one-time thing for me, and it just opened up my mind. It's wow, it's fantastic. And I was shocked because the diseases were similar as we had in my university, but the technology was the same. We're doing similar kind of procedures, similar kind of machines, but the academic level was something I was not used to. It was more formal, more structured. So it was something I was hungry for, and I loved it. I came back the second summer with them. And it made clear to me that I wanted to perform a real fellowship. In Spain, it was more an apprenticeship to go into a specialty. A residency is 4 years over there, and then there's no formal fellowships. So the last year, you kind of go more with the specialty you like, and then you just call yourself a glaucoma specialist or a retina specialist or whatever, but it is not the formal fellowship you guys have here or they have in the US. So I went for fellowship. I ended up at UCLA. I was an international medical graduate, so it's a little more challenging, and you have to prove yourself harder, that you're harder working, that you really want this and you're motivated. But things work very well for me. And then I thought I think I want to pursue a residency. I want to repeat my residency in the US so I can be board certified, I can continue the path of learning. And I was told, literally I was told yeah, you're very nice, but don't waste your time and your money. Like you have done the steps, you have done everything, but it's very, very challenging. You will not succeed. Somehow, I don't know why, but the planets align. And I was able to get in. First year I applied and I matched in the University of Minnesota. So I was very fortunate. I did not match at UCLA. I matched at a different university. And that's probably the best thing that happened to me, because there was a huge program in pediatric glaucoma. And I got to train and do a fellowship specifically for pediatric glaucoma, except that it was during intense training during 3 years. So I was very blessed, because never in the University of Barcelona and at UCLA I had as much experience as there. So then training was coming to an end. I had a job offer, and I still wanted to see a little bit more. So I had a couple of months of summer vacation, and I said to my chairman, I want to see other places. I'm going to observe, I'm not going to operate, but I want to see how others work, because that is something that enriches you, something you can bring to your own institution. And I went and I did a 1 month observership at Duke in pediatric glaucoma, and then at Children's Hospital in Los Angeles. We all do things differently, and just learning it is something that gives so much, and you just bring so much with you and become a better person. My first job was at Mayo Clinic. There was not a formal pediatric glaucoma department. Surgeries were done by a pediatric doctor that didn't want to do the surgeries, and an adult glaucoma surgeon that didn't want to do those either. So I came there and they were fascinated, because I got to have all the patients. I got to tell them what equipment I needed, and that I had learned from all the places I had been to. And I just started a clinic for pediatric glaucoma, which didn't exist before, and the patients start coming. I started doing clinics, operating rooms dedicated for children with glaucoma, and you fill them. So you create them and they will come. And that was an unbelievable experience. My time there, we started publishing, creating a book for surgical techniques in pediatric glaucoma as well. I was keeping my collaboration with Bascom Palmer, which I had, and I was recruited at Bascom Palmer. I've been now 6 years at Bascom Palmer. So that's the path. That's my path. So I had a lot of, it's not a straight path. I did some things I repeated twice. So I had 6 years of medical school, 1 year of surgical internship. That's probably the hardest thing I've done in my life. Doing general surgery after doing 7 years of ophthalmology was tough. I did 7 years of residency, 3 years of fellowship, and then observerships. So all these meant to me that I am truly invested in education. That's really what I want. I've seen a lot. I want to contribute. And I got awards for that. I was Teacher of the Year at Mayo Clinic. I was Teacher of the Year at Bascom Palmer, and got other awards on that sense. So it's truly a passion for teaching. It is like a calling, to do this. And I have certain positions, I'm the Associate Residency Program Director at Bascom Palmer, and also the Director for the Glaucoma Fellowship. But things don't come the way. When I was younger, I thought if you are good, they will offer you things. So yes, but not really. You need to know how to advocate for yourself. You need to politely ask for things, and show up and show them you are there. I'm here, that's what I do, that's qualified, that's what I can bring on the table. And that is something I learned a lot with the years. So we're going to talk about balance in academia after talking about myself. So, but what is even academia, right? So academia is an institution of higher learning, research, or honorary membership. So here we have a picture of an ancient Greek picture. So the word academia comes from the Plato schools of philosophy, 385 before Christ. So people they were together in a room, sharing experiences like philosophy. Sometimes it was arts. There was this willingness, a community pursuit of research and education and scholarship. So what we see in this picture is pretty much what we have today here in the auditorium. So we have a bunch of people willing to share ideas, to have a conversation about different topics. And that is brilliant. With the years have passed, and still the pursuit is the same or even bigger. And what's having it all? So we need to balance a demanding career, especially a career that involves patient care. There's a lot of stress. There's a lot of family emotions. We have a lot of load of emotions, basically, that other fields don't have. We work long hours. Usually it includes even frequent travel. We should do research and publication in academia, work for grants as well, and have a impact in education. And at the same time, we need to fulfill our personal life. So it's not an easy task to do. So I mentioned I worked at Mayo Clinic for 5 years prior to being at Bascom Palmer. And I think this is relevant because I'll shortly tell you the story of the Mayo brothers. So here you have on this picture, we have in the middle here, we have the founder, the Mayo, William Mayo father, and the two sons, Charles and William James Mayo. So the father was a general practitioner that worked in the middle of rural Minnesota, and became, when the war came, he was doing exams for soldiers to enroll in the military. And they had two sons, and he sent them, he involved them in the clinical practice right away, sent them to medical school in other places, and gave them the motivation to be the best well-trained person they could be. At that time, they traveled to New York, they traveled to Baltimore to get specialized and learn from other places and bring back home what they learned. They learned that for surgical procedures, you need to use gloves, because before they were doing procedures without even surgical gloves. And they created a community based on excellence. One of the best sentences said by William Mayo was, "The best interest of the patient is the only interest to be considered." And this is something that is so important to keep in mind today, because we have a lot of things in mind. We have productivity, we have to do this research and follow join busy schedules. But it is something, that's why we went into medicine, and that is what we should keep in mind. So then the Mayo brothers kept on, they hire other practitioners, other specialties, they look for the best. They send people even to England or other places to pursue the best training, and they had them back. And that is the culture of the Mayo Clinic. The Mayo Clinic had the 3 shields. And this is something that is true for that institution, but is also true for many other academic institutions, many others that I've been into. So they said there's 3 shields that and they are interlinked between each other. The main one is, as we said, is patient care. Then we have the research shield, the education shield. So there was the 3 main shields, and they are pillars of all academic institutions. And nowadays, one should be argued that we have a 4th shield, which would be the administrative or leadership part. And that is super important to start talking about this early in the medical career of everybody, of medical students and residents. So from this culture, it became the promise of lean in healthcare, which is an attitude. It's an attitude of continuous improvement, a creation of values, a unity of purpose, respect for the patient and for the healthcare workers and the entire team, visual tracking of where we want to go, and have a flexible regimentation. We will talk about the first shield, which is patient care. So we need to provide the highest quality care, focusing on the individual needs and outcomes, and be up to date with the medical innovations of nowadays. And this is extremely hard, nowadays that we have so many publications on research, so many advances, new technologies. Also, we are in the era of personalized medicines. We know we are all different. We know we can take data on what makes one individual different than the other, and we should provide a more specialized, personalized care. We also live in times that patients have higher expectations than they ever had, and more information on hand, and that is okay. We just need to know how to keep up to date with that. And also, an institution needs to provide their own research to keep up current, up to date. Nowadays, there's productivity metrics. There are institutions like my first job versus my second job. Mayo Clinic sees 25 to 30 patients a day, for example. Bascom Palmer, I see 60 or even more a day. It depends on the institution. And this is good and bad. They have the good things because you need to do your great technical job, but still give your humane and time to listen to the patient, your human touch. we, in my current institution, we get like a monthly productivity report, for example, how many visits, how many surgeries we've done, what's the percentage compared to the last year to that. So it's all these numbers. And then they even compare us with the other faculty and all these things. So what do? Like, we are asked to see more and do more, but we need to still keep the excellence. So we need to be efficient, like with clinic space, OR space. We have technicians, we do have scribes, for example. So those are ways to get around it, to try to get like that balance, like volume versus quality. And we need to prioritize. We need to know where to spend our time. In surgical care, also we want to be efficient, but we need safety protocols. So the worst thing is to be rushed and have run into a problem. We have preference cards for surgeons. We have a good flow in the and turnover in the operating room. So we have a pre-op area. Patients get ready. They go to anesthesia area, and then they go to the operating room and then to the post-op. So we do have a good turnover. That's something that can be improved. Anesthesia, we work anesthesiologists with CRNAs, and they do have resources, like they have anesthesia cards both for adults and pediatric patients. The layover also, it's basically the coordination of all team members. So we do have an OR control desk. So the middle of our operating room, it's like there's 3 desks with the panels and monitors that they control what's happening in every operating room. There's a person that controls and calls like, this OR, they think there's a vitrectomy that is about to finish. They're calling for the next patient, like before time comes. They have the patient ready. We have a pre-op bay area where anesthesia does the blocks. So this is a layover of, we only have 10 operating rooms, but we have this in blue, that's the OR control desk. And so there's different people sitting here. They have the big monitors of what's happening in under each microscope and what's happening in each room. So they know when to move the patients. So the patients come from the pre-op from outside to the red area. And the red area is an anesthesia base where the patients get IVs, they get blocks, and they get ready. So when you finish your surgery, let's say in OR1, the next patient is like one patient comes out, the other patient comes in. So that's the way we try to optimize the time, just to minimize the kind of space constriction we do have on the operating rooms. So that's about clinical and surgical care. How about research? So the institution needs to be a leading research institution to discover new treatments and therapies and translate those findings into the medical and surgical practice. Every institution has different strengths, but also they have strengths that are even outside the ophthalmology field. And the beauty of that is like knowing like where you're at, where the strengths are, and what's the possibilities of collaborations you have. We do actually have a research building. It's an 8-floor building, different labs with different researchers, and we do collaborate with them. I'm not a lab researcher. I do provide, like, for example, samples or collaborate with some of my colleagues here in the building. This building, we have the top floor is the Dr. Nasser Ibrahim Al-Rashid Center, which is like a brilliant place, like recently developed, and that has a lot of like very productive. We also have a genetic center, the John Hosman's Genetic Center, that we have biobanks and samples like collected. And we work with geneticists and genetic counselors. They come to our clinics, and we also like do sessions together with them. In the field of education, it's very important to understand the power of education because it ensures the highest quality of care and training of the future generations of clinicians and surgeons. There's no room for error in anybody. In an eye, like less than, I would argue less than other parts of the body. And in, for example, I do pediatric glaucoma in a child, even less, because it's a long life they have ahead of. So we need to handle with care. But there's other reasons to teach. Like as a trainee myself, I learn from, as a trainer, I learn from my trainees so much. It's contagious, the energy that somebody young that is there because they work hard to be in that position, to earn that competitive spot that is ophthalmology residency, ophthalmology fellowship. So it's contagious, like the spirit of like learning, wanting to do more. And it reflects on the time like a few years ago, like when I was on their own shoes. Also, there's the possibility of doing research and education, which is so important, and it's developed. This field is being developed more and more lately. It makes you more productive as well. It is true there's a steep learning curve, like how to learn to delegate and have a quality control, and a system needs to be in place. Different training programs, our own training programs, we do have 8 residents per year, so it's only 3 years residency. There's a surgical internship of 1 year and 3 years of residency. So we have a total of 24 residents. And we have several fellowship specialties. Glaucoma, we have 5. Pediatrics is currently 2. And this is in the central Miami. Then there's some satellites that have other additional fellows position. We've been #1 hospital in the U.S. News and World Report for several years in a row. And this is a report that is done by the opinion that other ophthalmologists have regarding the ophthalmology programs in the U.S. We also are #1 in residency training in the U.S. in different, in the ophthalmology time rankings and doximity rankings as well. And training and selecting your own residents is crucial because that can make your life like way easier or way harder. So we have a very selective, a very competitive and selective process. We put a lot of thought on this. It's also important to have a curriculum to teach and to give feedback because everybody can get better. No matter how you are, everybody can get better. Feedback is a very important component of the physician training and will guide the development of the skills and knowledge. There's 2 types of feedback. One would be the formative feedback. So it's like while you are doing a procedure, like you're seeing a patient in clinic, you're doing surgery, your mentor is giving you like active feedback, like, oh no, you should do this way, you should do the other way, this is better for this reason. And there is the summative feedback. So it's feedback giving at the end of the entire learning experience. So the feedback should be specific, exactly like focus on the concrete behavior rather than just general comment. It should be delivered as soon as possible after observing, because when it's fresh in memory is when it's more effective to correct something. It should be constructive, highlighting both the strengths and also the areas that the trainee can improve. And it should be reflective. So encourage the trainee to self-reflect and own that process. Formative feedback is generally more effective than summative feedback. And also, early start learning, like a first-year resident, will benefit more from positive feedback, like highlight what they've done well, encourage them, because it's hard to learn like a whole new world, a whole new discipline. But later stage learners will benefit more from negative feedback, like telling them like, oh, this you can get a little better if you do this way. This you could have done this other thing. And always remember to give feedback. It's good to do the sandwich technique. So you start positive, begin telling them something that the person does well. Then do constructive feedback, like delivering a specific feedback on the areas they can improve. And then positive at the end. Conclude with another positive comment of encouragement. Medical education programs, be open to the community is important. This is just the ones we have in the first 6 months. Now, we also are open worldwide, so we have a presence on the websites, and there's a Basque Compartment Learn website, for example, so this is a good way to reach. So everybody, everywhere, at every time, they can have on-demand lectures, CME courses, images, so it's like sharing knowledge. That's what matters today. Also, community engagement is important to do, like vision screenings, like for children, for adults. Because I do specifically pediatric glaucoma, we are centered on like training programs we have for other trainees that do like pediatric glaucoma in other countries that are, maybe they don't have any pediatric glaucoma specialists. And you would be surprised how many of them have nobody that could teach them. We do courses at national meetings and others, like the American Academy course, like we've been on a row, like for 12 years in a row presenting. We also have published the surgical books, the consensus on the World Glaucoma Association. We work on the rubrics, like how to give feedback, how to dissect the surgery into small steps and tell a resident, like, oh, you are a 3 on this area of the surgery, but you are a 5 on this other one. And we also have educational resources for patients and families. I showed this video before, which is a child undergoing an exam under anesthesia, okay? So that's a tiny baby, like super young child. So there's very little room of error for this. I mean, it's like it could have big consequences because of lack of expertise, things are not done correctly. So how do we teach? We develop a method, like we have a doll, for example, that we just like actually replace their eyes with models that you can see actually their optic nerve. You can simulate that you are checking pressure, like here. We're just checking pressure with a mask, simulating we are inducting like anesthesia, and then anesthesia tells us, oh, you need to stop, because sometimes like the child can desaturate, it can be a problem, and we need to interfere. So simulation is basic for us. We also like to engage people early on in their careers. We have a program, it's called a Student Outreach and Research Fellowship. So we get students early on in their life, and we teach them how to do research in pediatric glaucoma. We teach them foundation on statistics and other trainings as well. We have a program called Global Eyesight Scholar. And this is for more advanced training. Those are surgeons that already are fully trained surgeons and pediatric or glaucoma specialists that have jobs and positions in hospitals with a high demand of glaucoma surgeries. Here it was the original inaugural scholar. He was a physician from Brazil that had to take care of children with glaucoma and had no formal training. So he came to Bascom Palmer for 3 months. We just taught them, did wet labs with them and teach them. We just had one 2 months ago from Panama, same thing. Was doing pediatric glaucoma surgery, but he was like, I've never been formally trained. So we take them and try to teach them the most we can. And never stop learning, because life never stops teaching. That is so true. We also do live surgery. We can connect different surgeons in different countries. Like in this picture, for example, that baby you were seeing under anesthesia. So we were doing live surgery with Argentina and explaining how we're doing angle surgery and the difficulties you see, because sometimes you see an edited video and that looks beautiful, but that's different than what actually happens in the operating room. So it's nice to have these capabilities of connecting two parts of remotes in the wall and having intraoperative coaching and some teaching and different experiences that we all have. A wet lab is basic nowadays. It's a physical space, ideally with several stations, with a teaching station and others for the trainees to be practicing at the same time they are being taught. Models and instruments are needed. And also a curriculum. It's nice, a curriculum with an expert, that somebody that knows how to do things already teaches you how to use their hands, how to use different things. And also a curriculum that is autonomous, like you as a trainee can go by yourself and can follow that to be able to improve and be more efficient and more gentle with issues. And also, it allows the possibility of interacting. Like nowadays with the technology, it's just like interacting with other centers and colleagues. I don't know if any of you know where is the biggest wet lab, or will be in the biggest wet lab in the country that's been developed. Like here, you guys. So you guys should be proud of it. So the biggest station and everything, yes. I know you guys, it's under construction, but this is like an absolutely honor. And Bascom Palmer wants to model after you guys. And the idea is like if you can unite like the expertise of different parts of the world and have people that talk to each other, demonstrate, teach, like share experiences. It opens the entire wall. It's a win-win for both parties. Surgical simulation is fantastic because it allows you, like synthetic eyes, have 3D printed models, have improved the way we can teach so much than we had like few years before. So it's like portable. I brought some in my suitcase, for example, for the wet lab we're gonna do tomorrow. We're gonna have a wet lab tomorrow afternoon. So we'll practice this. So it has literally changed our life. Like we can practice anytime. And wet labs are not only for trainees and people that are starting. Like I honestly like to do this. I recorded this recently, for exhibit for the American Glaucoma Society, and that's like an ab interno goniotomy by manual. And you can become better, more refined. There's always a win. I don't think you ever reach a point when you think you're the best surgeon on the world, because there's something else you can do better and finer. We do courses, and courses are basic. We have been teaching pediatric glaucoma at the American Academy of Ophthalmology for 12 years. We are not perfect, as we said, like we talk about, we lack on deep sclerectomy on smaller children. That's why this year on the American Academy, we are like blessed to have like representation of the King Khaled. So Dr. Sesma is gonna take care of that part. And we have 3 courses approved this year, which is like challenging clinical cases in pediatric glaucoma, mastering pediatric glaucoma surgical techniques, and anterior segment dysgenesis. We are also in World Glaucoma Congress, European Society, and also we have virtual platforms to continue sharing knowledge. There's publications, of course, but those become obsolete. It's time to renew, it's time to do more. We had in surgery as well, and new projects coming up. So the next one we are doing that we are very excited is a book. There's a publication on childhood glaucoma around the world, like explaining the story of glaucoma, like the big picture, by chapters, and every chapter is going to be explained by a different case all around the world, and so it's a big project, like just stay tuned. And all this we can do because we have international collaborations. There is an institution, is the Childhood Glaucoma Research Network, that what it aims is just to connect together everybody that does pediatric glaucoma, for example. So they have learning resources, we do meetings, we advertise when we do anything, and we share like if there's like the algorithms or classification, we share all this. During COVID, we ship home, because there were no wet labs or it was canceled, so we ship home like some kits, like to do a little model of bionic or gonio lens and everything to practice, and a little video to do things. It allows for collaborative research and also for publications. There's a lot of work to be done. So thanks to this organization, we can like just partner, and everybody can lead a specific project. And I want to talk about also the administration shield. That's the 4th shield we added. So it's very important to talk about leadership. And the early on in the career of ophthalmology that we do it, the better. So leadership encounters like challenges, needs motivation, teamwork, have a strategy and vision, and achieve the goals. So to be a good physician leader, first you need to be the best physician you can be. Like we said, the needs of the patient come first, and that's always true. That will remains the first priority. We also need to focus on offering the highest quality care at the lowest cost, because that is value. If we can do that, we'll reach our care will reach to more people. We need to promote positive change. Like before, like you are number one and the leader, and you have reputation, you cannot stay like there. If you don't evolve and change, you will not continue to be number one. And be always open to opportunities. And be grateful and thank your team, because that's who makes it happen. And not also on following your, having some personal life balance. So your personal idea of happiness might be different than everybody else, and that's okay. Also, happiness might evolve in everybody's lives. There's different phases to life, and that's something when I was a little younger I didn't understand. I remember talking to my chairman, Eduardo Alfonso, and he was telling me this, and I was like, I just see like the present, like if it was gonna last forever. And then when you get older, you realize how a thing goes quickly, and phases come quickly, and sometimes you have interest in something, and this evolves to something naturally. Having children is a challenge. It's okay to ask for help and mentorship, like ask how other people have done it. Sometimes you face personal struggles and you're not there alone. Like whatever you do, like somebody else has been there before you. Listen to your needs and prioritize what's important for you at that stage. And it's okay to say no to certain things, like just choose. And remember, when time comes, like pay it forward. Remember like who helped you, what things were beneficial to you, and try to help others. Because the same as you have mentors that change your life, you can be the change of other people's life. So follow your path, take opportunities, open new doors, and beware that your plans might not turn as you initially planned. They might be even better. The key to success is attitude and mindset. You are in control. You need to define your interest and timing for things to happen. Keep on learning and have a vision for future. Think of leaving a legacy after you, and train the new generation, which is the biggest legacy you can leave. So having it all in academia, yes, it's a mindset. It's a mindset and it bases on team effort, excellent leadership, being open to change and have continuous improvement. and integrate the new advances in technology, research, education, and patient expectations. Thank you so much. Thank you.
Thank you very much. This was very inspiring talk and a very interesting, very successful journey. I will open the floor now for questions from the colleagues. Any questions to Dr. Elena? Fatma?
Thank you, Dr. Elena. I have a question regarding your path. You started with the first slide showing the path that you have taken. And I wanted to ask, since you put Plato, do you choose your path, or does the path chooses you?
Great question. Great question. I think a lot of times the path chooses you. I think your mindset being open, it just, people open doors for you. You just have to dare to cross the threshold and see what's there. And maybe that's not what you want. That's okay. You go back to your path. But I do think the path chooses you. That's why I think like I've been fortunate in many ways. You just have to be positive and open. Some people calculate, like calculate everything like minutiously. This is what I'm going to do, and this year I'll do this and the other. And life is not like that. And some people get like frustrated because this is not exactly how I was expecting, or it just wasn't the test in that exam, or that wasn't. And a lot of times things have a good reason to happen this way.
Can I follow up on that question? When we come to leadership, because there is a lot of young people in the young generation where they would say, I want to be a leader, I want to lead. And it comes to my question. Again, in leadership, is it in you to be a leader, or does life make you leader? Do you practice to be a leader, or it's whatever that comes and then you discover how you would lead?
I think it's a little like surgery. There are natural surgeons, but there are surgeons that are made. I think definitely training is necessary in leadership. It is something that has been obviated. Like in Spain, I had like, I wouldn't say zero, but it was new. We did some administration, of hospital administration, so it was part of but it was something new. I think that is something I saw more when I came to the US. The way of advocating for yourself, and that like shocked me. It's like, you sell yourself, people will see you as you present yourself to themselves. So I think you make yourself, we need training, we need to expose people. It's same as you do not learn ophthalmology just by observing. You need to be taught on the right direction. Yes. Thank you, great questions.
Any other questions?
Thank you, Dr. Bitrian. I have two questions. The first about the role of mentorship. And did you have some mentors, especially at the beginning of your transition from Barcelona and so on? And the other thing is that joining the international collaboration about childhood glaucoma research network, and how we can do that, because we are interested to join.
All right, awesome questions here. I'm loving it. So the first one regarding mentorship, that's a great question. Like, what do you do? Even at Bascom Palmer, we are like, do we assign a resident a mentor? Yes, we've done this. It doesn't work well. It's best if everybody individual, like we should offer and engage them and expose them and be open to them. But it is best, you're gonna find your best mentor for you, like personality-wise, that you're gonna click a little better, or have several mentors. This one will fulfill this area like of your development, and this another one. So I think in my case, it's been always, I just found people that I'm grateful because I learned this and I have more like affinity for this person, so I just learn from them. And always like being grateful. I literally remember when something clicked on me because somebody explained it that way, and it was like, I think I will always remember like certain things in surgery, certain things that somebody told me like, oh, why, when I was offered the consensus in glaucoma, somebody gave me the opportunity to work on that, and I was the youngest person. I didn't know what I was doing, but I did it, and they helped me, and they reprove what I did. So mentorship, it's good just to look for people. People are willing to help. Time is limited, but when somebody really wants and has their heart on it, they will truly mentor you. Mentorship is fundamental. Like you wouldn't get, like without guidance, you won't get as far ahead as you would otherwise. And regarding the second question, so the Congenital Glaucoma Research Network is open to everybody. It's like free membership, and we have like newsletters and things like, and every meeting, like at ARVO, that AAO, there's meetings we get together. We do some webinars. You can send me an email, or I would put also the information of just for the main administrative person that sends so everybody can join.
We'd be grateful.
Of course, thank you.
I have a question. Lots of the things that you do, especially in training and education and mentorship, you're not being paid for it. So why do you do it?
Good question. Yes, we are not. I am not being paid for. I'm director of Glaucoma Fellowship, which takes countless hours and meetings, residency, which takes weekends and time out of my, like waking up extra early. I do it because I truly believe in it. So that is true. It's passion, it's motivation, it's because that's why I'm there. If it all was money, I could go and find a different job. But this is what fills me, that's what makes me continue and happy to go to work every day.
Again, why do you do it? You have a passion. That passion is driving you to do what? Do you want fame? Are you doing it to be recognized? Why do you do it?
I like seeing young people grow and develop. When I do something, it's like, oh, it turned out well, I have proud on it. But when I have somebody that I guide them and they do it well, they have a surgery that succeeds, something that they accomplish, that makes you even prouder when you know you made an impact. Because I had that experience that somebody taught me and made an impact on my life. So I think I'm reviving this. When I see that hungry person, it's like they're hungry, they want to learn, they just give it all. They work so hard. That to me is like what keeps me alive.
So you're paying back your mentors by training someone else and being his mentor.
I think so.
Then my follow-up question is, how do you choose the people that you would like to mentor?
That's also a very interesting question. So there's at all levels. If I see them that they are motivated, I would take them. So I have, of course, residency. They really are very meticulous choosing, because if you have a resident that doesn't work well, like the department fails, it's just like the emergency room volume is too high. So that we really pick somebody that we know is going to be strong enough. At other levels, like sometimes research, there's people that don't have interest. It's okay, everybody chooses their path, but I'm going to invest my time on somebody that I know and they are going to invest their time on me. Like they work, I will give back. It's like an exchange this way.
Okay, and how would you answer someone who, our profession now is shifting its directions. You've mentioned that the only interest that is there is the interest of the patient. Now there is a general shift that we should focus on the staff, because we're becoming like how shall I say, a supermarket or a travel agency, where your focus is on making the employees happy, because a happy employee means a happy customer. And there are even people who are calling our patient as customers, which they are not. We were taught in an era where we thought, as you said and as you mentioned, the primary responsibility is to our patient. We're giving up our life, our social life, sometimes even giving up on family occasions to serve our patients who are in need. And we thought we are doing something great and a great impact. Now there is this shift that ophthalmology and medicine in general is shifting from being a mission to being a job, which means if you want me to do something extra, you have to pay me. If you keep me 1 more hour, you have to pay me. If you want me to work on weekends, you have to pay me, which is changing the whole structure of medicine and how we practice. What would be your thoughts on this?
Yes, that unfortunately is like the administrations, and in the US it's even more than I would say in other parts of Europe. So there's a lot of burnout, physician burnout, and that's what leads to that, like, oh, the physician went or I leave, and then I need this doctor. So what we are working on is like there was increasing compensation. That is crucial, and at Bascom Palmer we went through this. So that patients feel value, and one part of feeling value is the compensation, the type of work they're doing, and the quality of job. We are getting like a scribes, like they'll just type for us. They just like they're ophthalmic technicians that are also scribes. So our job is made a little bit easier on that part. Administrative assistants also that they are competent, that everything that is non-medical, that is like alleviated as much. As educational, I have educational administrative assistants as well. So all these things I don't touch, I don't do. I have other people that do this for me. I think that's the way. Yes, there's more volume, there's complex patients, it has to be in a timely manner, so it is a big pressure. And the burnout, there's been people that have left medicine in general, not only ophthalmology, because of this issue. Or they have switched careers and leave academia because they feel the burden. So.
Yeah, one of the problems, as you mentioned, that we're facing now with the advancement of the practice of medicine is the extensive documentation that is required. And so many forms that you have to fill. So most of the time of the physician in the clinic is lost or maybe wasted even in printing up or writing up stuff on a computer. You've mentioned a few solutions that can be done which will alleviate the effort on the physician and give him more time with the patient. In the future, with the development of AI and the involvement of technology, how do you see the role of ophthalmologists? Will we be put on the side and just see complex cases or cases that AI might not be able to cure, or will AI be supportive, or will AI take over?
I think AI will be supportive. I don't think it can take over. I think you'll still need the experience, the human experience, but AI can take over like dictations, voice recognition, summaries for patients, and all these things that now we are relying on a scribe, because yes, we have scribes, but in every clinical note, there's a statement of the scribe saying, I'm not responsible what's written here, Dr. Vitrian is. So we also have this issue. So we have help, but all the responsibility is on us. I think AI will help us with this, with analysis of images. Is this worse? Has this like corneal opacity got any worse, etc. Like same as it helps a little bit with the OCTs and the visual fields progression analysis. So that saves